Very welcome to the Swedish Collegium for Advanced Study and to the first seminar of this semester. Happy to hear so many people here and to see so many people here. We have the great pleasure and honor of welcoming Anat Biegon, who will talk on the long road to equity for women in medicine. And Anat Biegon is a natural sciences fellow here at Scas and otherwise a professor of radiology and neurology at the Renaissance School of Medicine at Stony Brook University. Anat Biegon was born in Poland and raised in Israel, where she completed the bachelor's and master's degrees at Tel Aviv University in chemistry and biochemistry, respectively. She received a PhD in neurobiology from the Weizmann Institute of Science in 1980, and she was a postdoc at Rockefeller University in New York. Since then, she has held positions in academia and also in the pharmaceutical industry in the US and Israel, most recently, as I mentioned, as professor of radiology and neurology at Stony Brook University, Renaissance School of Medicine. Anat studies sex differences and hormonal effects in the brain, and most recently focusing on Alzheimer's disease in a project funded by grants from the National Institutes of Health. Her research has been widely published in a number of high-profile journals, including Science, Proceedings of the National Academy of Sciences, and Neurology. She's an associate editor for Frontiers in Neurology and section editor for the Journal of Personalized Medicine. Her education and outreach activities, and they are many, include creating and teaching a class on issues in women's health and gender-based medicine, which was offered to medical students between the years 2016 and 2022. Also organizing a virtual international meeting titled The Long Road to Equity for Women in Medicine in 2021. While here at Scas, Anat will be working on assessing baseline knowledge, skills, and levels of implicit bias regarding sex and gender-based medicine among Swedish medical students and practitioners. Also, the level of implicit gender bias among medical school and non-medical university students, and examining how these change after exposure to an educational intervention. So with these words, warmly welcome Anat.
Thank you, Christina, for this kind introduction, Kotemoron. And I would like to start just one update for my CV. Since I applied to this program and was accepted, I actually retired from Stony Brook. So I decided to devote myself to the activities that were just described. And I want to start with a personal story. So back in 1976, when most of you were not born yet, I started graduate school. This was my first year of graduate school, and I was just about to embark on my very first experiment, a laboratory experiment. What I was going to do is anesthetize a few male rats and a few female rats, because my project had to do with comparison of the two. And then perform surgery, and then do injections and manipulations and great things. And I realized as I was bringing the rats into the lab that I wasn't sure what dose of anesthetic I'm supposed to give them. I graduated to rats just then from mice, so I knew the mouse dose, I didn't know the female and male rat dose. So I call up my mentor and I said, Menachem, how many milligram per kilogram of pentobarbital do I give my rats? And he said 50 milligram per kilogram. So I injected all of my rats, and all of the females died. Yeah, exactly. So after blaming myself and feeling terrible, I dove into the literature. 1976 meant going to the library and looking at journals. And I found that back in 1954, a very famous Nobel Prize winner, biochemist, Julius Axelrod, has described in detail the effects of sex hormones on drug metabolism, with barbiturates as an example. And what he discovered in 1954, I was born in 1954, that the female hormone estrogen slows down the metabolism of large families of drugs that are metabolized by a specific liver enzyme system. And the male hormone, testosterone, actually accelerates the metabolism. So after puberty, if you give the same dose of drug to males and females, the males make short work of the drug really fast, and in the females it hangs on. So giving the same dose of barbiturate to males and females, the males slept for about 2 hours, which is what they were supposed to do, and the females died. And to achieve surgical anesthesia without any death, in the females, I had to give them 1/2 of the dose that I gave the males. And this was all explained in this paper from 1954 that never made it to my awareness. And then I realized that I'm the only person in my research group and in the building and most of the institute using females in research. So no one knew what the female dose is supposed to be because no one used females. So I learned my lesson. I lowered the dose to 1/2 of what it was. I killed a few females, died by overdose of a sleep medication, and I figured, well, I'm sure that in humans this is all known and documented because we're just rat people, so we don't know. But among people and physicians and whatnot, this is probably well known and taken care of. Otherwise, women will be dying right, left, and center. They use sleep medications a lot. So fast forward to 2013. Okay? Women were dying right, left, and center all of these years. But it took until 2013 for the first ever acknowledgement from the Food and Drug Administration in the US that women actually metabolize this class of drugs slower than men, and this has dire consequences, and therefore the dose for women should be reduced by 1/2. Same story. So the drug is Ambien. It has many different names, brand names. I don't know what the brand name is in Sweden, but it's a very popular sleep medication. Most of the people who use sleep medications are women. The drug was developed in about 20, 30 years ago and had very good safety results and was approved for use at a recommended dose of 10 milligram. And then after post-marketing studies, it became apparent that there are many incidents of morning impairment, mostly in women. Morning impairment means you wake up in the morning and you're still drowsy, and you get in the car and you get into an accident and you die. That's one of the manifestations of morning impairment. So they actually brought in men and women to the FDA laboratories. They gave them the drug, they put them in a driving simulator, and they measured the levels of the drug in the plasma in the morning. And it turned out that, yes, women were much more impaired in the driving simulation after taking the standard dose, and the levels of the drug in their plasma was twice as high as in the men, which didn't need more explanation. So this is the first ever sex-specific recommendation by the FDA. If you read down where the little orange thing is, the recommended dose of zolpidem for women should be lowered from 10 milligram to 5 milligram. And you may be asking yourself, as I was asking myself, how is it possible that it took 30 years for this to come out? And to answer this question, we need to cast our eyes way back into history. So here's some historical perspective. Some of you already figured out my code. Red is things that are bad for women, and blue is things that are good for women. So Hippocrates is considered the father of Western medicine. Like many important things, it doesn't have a mother. So he apparently, we never know its attribution, wrote 2 books called Diseases of Women. And in these books, he set out description of the common diseases that affect women and some suggestions about mechanism and treatment. In these books, he actually brought up the concept of hysteria, which is things that have to do with the uterus, hysteria in Greek. It wasn't an original concept. Actually, some Egyptian physicians were talking about it centuries before, but he basically explained the female-specific diseases by the wandering of the uterus. So this was his version of hysteria, and the concept was picked up many years later by people like Charcot and later Freud, and they used the term hysteria to describe mostly mental, behavioral affliction of women, and we live with the consequences till this day. I put it here as 500 BC till 1900 because hysteria is a medical diagnosis in the DSM, which is the Bible of psychiatry, was only removed as a diagnosis in the middle of the 19th century. But I think it lives with us. I mean, it's not in the books anymore, but it's in the lives and the minds of lay people as well as physicians. What it really means is that many symptoms and diseases that women complain of are in their head. It's a bad concept to live with. So what happened between 1200 and 1800? This is the ascendancy of the, I'm talking about the West, Christianity. So women were seen as inherently evil and sexual and easy targets for the devil. Women, as often as not midwives or herbalists, represented more than 90% of those executed for witchcraft in Europe as well as in the US. So you know about burning witches. It was a very favorite pastime in the Middle Ages, and most of the victims were women, and a lot of them were midwives or herbalists. So these were the early female physicians who worried mostly about female afflictions. They were burned. And modern medicine and physicians took ascendancy. And women were not allowed in this. They're not allowed into medical schools. And this quotation here from 1859 is from the Journal of the American Medical Association. And it reads, the proposition that women as a sex are not fit to practice medicine, that their weak physical organization renders them unfit for such duties and exposures, that their physiological condition during a portion of every month, this is the menstrual cycle, disqualifies them from such grave responsibilities is too nearly self-evident to require argument. Spoken like good science. So if this isn't bad enough, in 1977, 1 year after I performed my lethal experiment on females, the FDI actually excluded women of childbearing potential from participation in early clinical trials. So, you know about clinical trials. This is how you decide what is the safe dose of a drug, how often to give it, and then you determine efficacy, etc. And it was really not common to include women in clinical trials even before this edict because they have cycles, they're unreliable. But then it became the law. And of course, you can guess that the purpose of this was to defend the unborn fetus. If you thought for a moment that this is to defend women, think again. So this is why women of childbearing potential, broadly defined as the capacity to become pregnant, which covers all women from age 14 to 51. So this means that clinical trials performed after 1977, most of those performed before also, the early ones that determine how much of a drug you can give and what is safe and what is the treatment regimen, were performed exclusively on men. And then the doses and regimens that were declared safe in men were applied in women. Okay? Some good things happened too. In 1920, US women got the vote. In 1945, Harvard Medical School removed the ban on accepting female medical students. In 1993, that's a biggie, the FDA completely reversed its position. The position from 77, no women in clinical trials. You will not get approval for a new drug unless the clinical trials include women. They also mandated analysis of the data by sex. You have to separate males and females and report the rate of adverse effects by sex. So the first thing is happening because it's a condition to get permission to start a trial. The second thing is not happening. It's very hard to enforce, and there is strong resistance in pharma and among investigators to do data analysis by sex. And the same year, the NIH, I mean, this is sort of American bent. I spent 30 years of my life in America, but I hope you know what the NIH is and the European equivalents. So and if not, if I'm too American, stop me and ask. So the NIH issued a requirement to include women in NIH-sponsored clinical trials. So clinical trials can be sponsored by industry or sponsored by investigator initiation supported by a grant. So NIH is telling people, you want a grant for a clinical trial, you have to include women. So this was a big revolution. In 2004, Marianne Legato published the first book on gender-specific medicine, which was like taking Hippocrates and bringing him up to date. And only in 2015, the NIH issued a mandate to consider sex as a biological variable in NIH-funded research, which is preclinical animal research. So when I was killing my females, 95 to 99% of animal experimentation in the world was done on males only. In 2015, it was the same. So it needed intervention because someone realized that if you do not start looking at males and females before you get to the clinical, you will be missing a lot. And I will try to get back to it later. I'm not sure I'll have time. So now you are absolutely expected, severely expected to include females in your mouse and rat research. And this met with a lot of consternation on the side of researchers. So what was Hippocrates saying, or what was Plato saying? I think this is very deep text. I really love it. Because contrary to what you may think, it is more relevant to women's health than our modern attitude. So what they're saying is that the womb, the matrix of women, becomes a wandering thing when the organ remains empty beyond its proper time. It becomes discontented and angry, and it breaks loose from its tethering and begins to travel about the body, like in an upward direction, for example, interfering with breathing and circulatory function, driving the woman so afflicted to every extremity, causing every kind of disease, including strangulation if reaching the chest, until such time as it has been sown and rendered again content and docile. This animal that longs to generate children, if not constantly irrigated by males and anchored by pregnancy, causes the sufferer the most extreme anguish and oddest behavior. Now, why am I saying this is more progressive than current medicine? Because he says every kind of disease. He doesn't say diseases of reproductive organs. So he has the reason wrong, and he has the treatment wrong, but he has the observation right, that there are many disorders, diseases that are affected by sex. And there are some other things related to medicine that are affected by gender. So here's to Hippocrates many years later. We now believe, and we have a lot of evidence, to show that sex and gender affect all aspects of medicine. Sex and hormones affect disease prevalence. Sex and hormones affect disease presentation. Sex and hormones affect response to drug. You heard about my dead females. This includes an effect on metabolism and pharmacokinetics, which directly impacts the safety of the drug. Too much of any drug kills you. There's no drug that has no side effects that may eventually kill you. And the pharmacodynamics, which is actually the efficacy of the drug. Sex and hormones affect disease outcome. And gender affects diagnostic speed, diagnostic accuracy, treatment choice, treatment intensity, and of course, outcome. And since we have limited time, I will try to give one example each of one or two examples tops of each of these concepts, but there's a lot more, okay? So I just said that there are sex differences in disease prevalence, and they're very, very, very common. So just starting with the letter A and going down the alphabet, attention deficit hyperactivity disorder is mostly a young boy's disease. So female make only 25% of this population. Alzheimer's dementia is 2/3 female. Autism is, again, majority of boys' disease. Autoimmune diseases of many different ilks, the example here is lupus, is 90% females. There are other examples that I just started jumping down the alphabet, and I'm only talking about disorders where the prevalence difference is more than twofold, okay? Relative risk of 2 or more. If I was counting diseases where the difference is 10 or 20 or 30%, but even just counting these, you know, we would be here all day. So arthritis is more common in women. And you're asking, which kind of arthritis? Osteoarthritis? Rheumatoid arthritis? Both. Cluster headache is more common in men. Everyone knows about migraine being more common in women, but actually cluster headache is a different kind of headache, pretty painful, and men represent more than 2/3. Depression is more common in women. Migraine is more common in women. Multiple sclerosis, it's an autoimmune disease, more common in women. Again, 2 to 3-fold difference. Osteoporosis is much more common in women. And all pain-centered diseases are more common in women. Fibromyalgia is 90% women. And I put traumatic brain injury here just for kicks because we don't think about it as a disease. It's an acquired thing, but it can kill you. And it's about 2/3 or more, especially severe head injury among men. And if you see a pattern here, it's not a coincidence. You see more red than blue. It's true. There are more diseases that are more common in women. And also, I hope you see a difference in the kind of disorders. And I'll put it this way. How long does it take you to die of arthritis? Trick question. You don't die of arthritis. You just suffer. And you suffer for many years. And it's barely treatable and not curable. So here's a life of going back to the doctor with your arthritis, or your depression, or your migraine, or your multiple sclerosis, or your osteoporosis, or your pain disease. These are all chronic, sometimes treatable, never curable. What do men do? They die of a heart attack. This is just where this has come from, you know, just to impress on you that this is not data from a 20-person study in Boys Town, Indiana. And also to impress on you, this is not race or culture dependent. So this is the landscape of autoimmune disorders, a WHO study, and we're looking at lupus. And lupus is 80 to 90% female in the USA. It's an ugly disease, but it doesn't kill you. It's in the US and in Denmark, in England, France, and China. Sjogren's syndrome, another ugly disease, doesn't kill you. US, France, Japan, China, India, all of these countries, a very high level of prevalence among women relative to men. The only autoimmune disorder I know of which is more common in men than in women is ankylosing spondylitis. You probably never heard of it, but you may have seen these people. They look like this. You have bamboo spine. Your spine fuses and you becomes rigid. Ugly disease. Doesn't kill you. Men are the majority in this one. Rheumatoid arthritis, as we said, is more common in women. Again, across countries, across ethnic backgrounds, across races. We mentioned multiple sclerosis, and then these are two autoimmune disorders that affect your thyroid, Graves' disease and Hashimoto's thyroiditis. Very, 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 very common in women relative to men. All of these diseases are chronic, barely treatable, not curable. So what does it lead us to see? Just to summarize the whole landscape, and I don't have the time to give all of the examples. As far as disease prevalence goes, poor health is more common in women. Or women spend more days of their life being sick than men. How is this expressed? Women between the ages of 19 and 45 account for 2/3 of hospitalizations. These are US numbers. Women in general account for 2/3 of all doctor visits in the US and other developed countries. Women live significantly longer than men. We know that the older you are, the more likely you are to have different diseases. Women are more likely, we just went through that, to suffer chronic and incurable diseases. And of course, what I call the gynecological package. Menstruation, pregnancy, childbirth, breastfeeding, and childcare have adverse effects on women's health. We're not going to go into many examples, but you know that. Okay. So done with prevalence, let's talk about disease presentation. So this poster came out when I was still, working in Stony, Brook, and it's an attempt to popularize what has become apparent starting in the 1980s, 90s, through the work of a few female cardiologists. Heart attacks do not look the same in men and women. So here is a guy having a heart attack. Okay? Left side, chest pain, you're killing over. So this is the symptom most common in men. This is the symptom. There is, the pain radiates down your left arm. You have shortness of breath. Very easy to recognize. Classical heart attack. Women may have these symptoms while having a heart attack, but they're also much more likely to have other symptoms as their leading symptoms, like nausea, fatigue, cold sweat, feeling like they have a heartburn or sudden dizziness. What does it mean? If you are a physician and you went to medical school before this poster came out, or even after, you will have women with a heart attack and not recognize it. To make things worse, the women themselves do not recognize it. Everyone knows that this is a heart attack. Which means that even though women are less likely to have a heart attack when they are young, they are much more likely to die of it if they have a heart attack. And there are other diseases with differences in presentation. Not all of them have such dire effects. A little bit more about drug, and I'm focusing on the cardiovascular system for a reason, because this is where our explanations, ingrown explanations that go back to Freud, that everything is in their head, doesn't apply so much. The heart is a simple pump. It either beats or it doesn't beat it. So let's talk about the effects of cardiovascular drugs. We said there are sex differences in response to drug. So this is a pretty comprehensive list of the families of drugs that are used in the treatment of cardiovascular disease nowadays. And all of them, besides Lasix, a diuretic, are either not effective in women or give them more adverse effects, or both. Okay? So it's like a double jeopardy, and may explain some of the excess mortality. So aspirin and digitalis, I want you to just go a little bit in depth to show you what kind of data these statements are based on. This is a monster slide. So let's see what we can make of it. Public health public health study in the United States, 1989. 1989 is after 77 and before 93. You can all figure it out. So this was supposed to be the pivotal trial that will decide whether aspirin can be used as preventive medicine against myocardial infarction, better known as a heart attack. It was a large study and well designed, randomized, double-blind, placebo control, whatever that means. It's good. 22,000 subjects participated in this study. And the result, this was pretty high dose. The doses were lowered later. 5 years of follow-up. So the idea is, here you take people who are sort of at increased risk for heart attack, like they're more than 55 years old. You give them the drug for 5 years, and you count how many got a heart attack later, or within the follow-up period. And this is very impressive. This means that the treatment reduced the risk of a myocardial infarction by almost 50%. Boom. Bayer got a license to print money. Okay? I hardly know a person over 60 who doesn't take a baby aspirin a day. The number of women in the study was 0. Okay? It was okay this time. It was the law. So we go to later studies that are futzing around with the dose, etc. So this is another study with no women, lower dose, and still a significant reduction in myocardial infarction. Then they start mixing some women in. It's sort of interesting. As long as the men are the majority, the drug is still effective. Oops, wrong direction. And then the US decided to do the study to end all studies. 40,000 women. No effect. 0. No change in myocardial infarction in 40,000 women given what was then the standard dose of aspirin. Did anyone stop prescribing aspirin to women because of that? Ask your mother. Okay. Digitalis, another heart medication. This is old medication, so basically grandfathered into practice without much clinical trial. So a group of trialists in 97 decided to see whether in a clinical trial Digitalis really makes a difference in survival and hospitalization of patients with heart failure. 6,800 patients, 25% women. And the study showed that the drug reduced hospitalization among patients with heart failure and had no effect on mortality. Hallelujah. Then a subgroup of the group said, but we didn't really look at men and women separately, and we have indications that heart disease may be a little different. So they did a retrospective analysis by sex. They looked at the same data again, just separated the men and the women. And they found that the rate of death among women was increased if they were given the drug. And the rate of death among men did not increase. So Digitalis is a healer for men and a killer for women. So it's not just a difference like effective, non-effective, it kills women. So what do you do with that? You cannot change guidelines or practice based on a post hoc analysis that was not planned, right? You cannot repeat the trial and do it, sex stratified, because it will be highly unethical, because you're already expecting that the women will not respond or they will die. So you're not going to do an experiment to prove that the drug kills someone. So what do you do? Nothing. For a while, nothing. And then people did clinical trials with lower doses of digitalis, and it turns out that if you have the dose of digitalis, women can actually have a benefit. So this is outcome. We talked about drugs, drug response. I mentioned it, now I'm showing you numbers. Women are less likely, especially young women, premenopausal, are less likely than men to have a heart attack. But if, God help them, they have a heart attack, they are twice as likely to die relative to men, especially if you're looking at the group under 50. And then as the age of occurrence of the MI increases, the difference between men and women in mortality due to MI decreases, and in the very old and frail, men actually are more likely to die of heart attack or anything than women. Another outcome, sex differences in surgical outcome. This is something that I've been struggling with, we in the field have been struggling with for years. We have seen time and time again that women have worse outcome in surgical procedures, all sorts of surgical procedures. So this is an example of a study from 1985, included about 3,000 patients, and the surgery in question is percutaneous transluminal coronary angioplasty. It's basically opening up your clogged arteries, okay, by pushing something through a balloon. This was hailed as very safe and very good surgery with very low mortality, if the data is not segregated by sex. Once someone took it into their mind to segregate the data by sex, it turned out that in-hospital mortality due to the surgery in women was almost 2%. This is not negligible. This is not low mortality, only 0.7% in men. The surgery-related mortality was nearly 6, so this is all in-hospital mortality. Mortality directly related to the surgery was 6 times higher in women. And mortality with emergency surgery was 5 times higher in women. And multivariate analysis, which means you try to control for everything that can feed into this, indicated that female gender was an independent predictor of lower success and early mortality, and was the only baseline predictor for PTCA-related mortality. Now, why is that? So at the time I was pondering this, I thought, well, it probably has something to do with the catheters they use, because women have smaller arteries. So I know from bitter experience that if you use a men's-sized catheter in a woman's-sized artery, you blow it, okay? So perhaps this is it. They were using standard-sized catheters. Well, years go by and people tell me, well, this is an old study and now we are using the proper catheters and everything is fine. But in 2015, in a study of 100,000 patients, 25% women, this is still true. Despite adjustments for baseline risk and hospital course, short-term mortality is higher in women than men in this specific surgery. Now, why is that? So, you know, being trained in the biological sciences, I always look for the physiological reason. This study came out, 2 studies back-to-back, came out in August 30th. And what they showed is that patients have better outcome when the surgeon is a female. Now, when I was talking about the PTCA studies, etc., why didn't we know it then? There were no female surgeons. The entry of females into the surgical professions is the slowest among medical fields. So even today, surgeons are a minority, females are a minority among surgeons. Sweden leads the way. So in Sweden, 35% of surgeons are women, as compared to 48% of physicians. But in other countries, the proportion is much lower, and it took a long time before we got there. So this comparison basically couldn't have been done before. But now that it was done, so there are 2 studies back to back, a Canadian study of 1.5 million patients found that those treated by male surgeons were 25% more likely to die. This is a long-term mortality outcome study than those treated by female surgeons. And then there's a Swedish study. So this is all surgical procedures and specialties. A Swedish study limited to just gallbladder surgery, 150,000 patients, found much higher rates of complications and longer hospital stays when the surgery was performed by male surgeons. And if you're surprised by that, let me just give you a hint. 2/3 of the patients in the Swedish study were women. Okay? There is another study that was published last year from the same group that published the long-term outcome study, the Canadian group. It was based on 1.3 million patients, all surgical procedures and 30-day outcome, which is closer to the time of surgery. And what they found, interestingly, is that the disadvantage to patients being treated by male surgeons was exclusively in women. So it was a question of discordance or concordance between. So it's not as simple as, oh, women are better surgeons than men. It's a little more nuanced. So when men and women perform surgery on men, the outcomes can be pretty much the same. But when men perform surgery on women, the outcome is much worse than if women perform surgery on women. Now, chew on this. So we finished with outcome, and now we're talking a little bit about the effects of gender. Okay? So actually, we just talked about the effect of gender, I think, you know. I basically had a complete mind change after reading these papers. And I thought it was biology. I guess it's really, gender. So women have a 50% higher chance than men to receive the wrong initial diagnosis following a heart attack. Take a Valium and go home. You have heart palpitations, you're fatigued, you have all of these symptoms that are not the symptoms of a heart attack, and we know that women are, weak complainers. Take a Valium, go home. Women with suspected coronary disease are less likely to undergo investigation or receive treatment relative to men. And they have consistently poorer outcome. You saw that. These differences are prevalent even in highly developed healthcare systems such as the US. Globally, coronary heart disease remains the leading cause of death in women. So, you talk to women in a community and you ask them, what is the biggest cause of death among women? And they'll say breast cancer. It's so not true, okay? Cardiovascular disorders is the #1 killer of women and men. Cancer is the second cause of death among women and men. Iatrogenic death, which is medical errors, is the third most common cause of death. If you look within cancer deaths, breast cancer is not even the #1 cancer death among women. Lung cancer is, okay? So perceptions are, who is paid to get this around? So I'm going into, kind reasons and not very kind reasons, but heart attack has traditionally been considered a male disease and has been understudied, underdiagnosed, and undertreated in women who, like their providers, may attribute symptoms to stress or anxiety. So that's the gender-based explanation, and there are some physiological possible explanations I won't bore you with because it's too technical. Okay, so bias can have consequences, but we don't just say it, we want to try and prove it. So is there a contribution, is there a real contribution that we can measure to the bias against women among medical providers? And for this, we have to thank some researchers in Harvard who invented a tool called the IAT. It's the implicit association test. It's a way to measure implicit subconscious bias. I don't have time to explain. It's not a bad tool. It's not perfect, okay? So it's used a lot in research on on race bias. Race bias is a much more popular area of research than sex bias. So there's one paper that actually looked at bias in the context of medicine. And 503 cardiologists, all men, were first tested for their gender bias on the spectrum of men strong, women weak, men risk taker, women not risk taker. So not surprisingly, the large majority, more than 60% if you combine all of these cardiologists thought that male are more likely to take risks and that men are stronger. And we could put a number on how strong the bias was. You measure the difference in response time when they are associating something that they think of as male characteristics with a female face, for example. So this is qualitative. So every one of these cardiologists had a number associated with their bias towards men as being risk takers and their bias as men being strong. And then the practice of these people, of these cardiologists, when they have men and women present with signs of possible coronary disease, was examined. So this over here is patients with symptoms suggestive of coronary heart disease. What is the likelihood that the cardiologist will prescribe angiography? Angiography is the good diagnostic tool, but it's expensive. All right? So the physicians who had the lowest pro-male bias and the highest pro-female bias were the ones more likely to prescribe angiography to women. As their bias towards men being risk taker increased, their likelihood of prescribing angiography decreased. And the opposite on the male side, okay? So the physicians who thought men are real risk takers and women are not, were the ones who prescribed more angiography to men and considerably less angiography to women. And the picture is pretty much the same when the patients were presenting with an abnormal stress test, although the absolute numbers of angiographies were higher. So it does translate into practice. Okay, so time to do something about it. In 2004, I scripted a syllabus on gender-based medicine that I thought would be helpful to teach to medical students because I already knew all of them, or most of it. I couldn't find a place for this syllabus for 20 years, more or less. So I was told by the dean of medical school in Tel Aviv University he can give me an hour in the epidemiology section to teach this. And, you know, medical curricula are dense and you cannot add anything, you know. So in 2016, there was a big upheaval in medical education in the US. All medical schools were required to reform their teaching, to conform with the new times, whatever. So every medical school had to come up with a plan how they're going to integrate and renovate and whatnot. So the medical school I was working at the time, Stony Brook, I offered them to do a curriculum that is based on men and women from the beginning, from conception to death. You know, teach every subject as it applies to men and women. They said that's way too radical. But they added something they called selective classes. So students were made to choose one of 6 classes besides the regular curriculum that they had to take in order to graduate. And this was based on faculty suggestions. So I suggested my syllabus and it got accepted. So in 2016, I started teaching a class called Issues in Women's Health and Gender-Based Medicine. It was so my curriculum was originally a 1-semester curriculum, 1 time a week, 12 meetings. So this was condensed into 1 month. And what we did is I had a partner, another PhD. We gave 3 or 4 core lectures about the biology of sex differences and how hormones affect this, that, and the other. Then we had guest speakers, all practicing physicians, almost all of them practicing physicians, who talked about disease entities and how they are modulated by sex. And then the students, to graduate the class, had to pick a subject related to sex differences in medicine, anything that is interesting for them, do research on it, and present it to the rest of the class. So this really exploded the number and type of topics. So we have inflicted this on 154 students, and 133 of them actually provided feedback. How do you evaluate a class like this, since there is no class like this? So one type of evaluation is sort of standard, did they like us? So the medical school does that, were the speakers well informed? Did you like the class? Okay, so we had that, but we wanted to evaluate knowledge. How do you evaluate knowledge? We hardly had a year where the guest lectures were the same, because our physicians were busy and they kept shifting or leaving the institute or whatnot. So the material, as far as specific diseases are concerned, changed every year. So we couldn't do a knowledge questionnaire about, thyroiditis if we didn't have thyroiditis. So we decided we will capture, there's no way we can, this is like alternative medicine, okay? All of medicine. Of course, we cannot capture it in 1 month. What we want to do is raise people's awareness that differences exist, so they will look for them and inhale them in their practice of medicine. So we decided to use one question that will capture, we thought, the knowledge part. The question was, why are women twice as likely to go to the doctor? You saw, yeah? So, and we had a theory. We thought, they will say, because of the OBGYN package. And then after months, they'll say, yeah, the OBGYN package, but also autoimmune disease, and also this, and also that. So we will not, we're not going to argue with their answer. We're just going to expand it. They'll learn more. So this is how we'll see whether we made a difference or not in knowledge. So this is a list of the lectures and student topics that we had in the years the class was active. We have limited the number of students per iteration to 24 because we had 8 student sessions and we wanted everyone to present in pairs or in thirds. So if we had bigger classes, we wouldn't have time for everyone to present and research a topic. And I want you to look at the students' topics because I think they are very interesting. Most students chose a topic that was within the area of specialization where they were going. So this is 4th-year medical school. In 4 months, they're going to start residency. So those who were going into plastic surgery chose transgender surgery. How do you make a man into a woman surgically, or vice versa, as their topic? Those who were going into ophthalmology chose Behçet disease, which is an ugly eye disorder you don't want to know about. So this is the genital surgery for gender transition. The students were very interested in gender transition. So they chose repeatedly topics related to transgender. We only had a class on transgender very late. We couldn't find someone who does that and is willing to give a talk. So eventually we found a lady endocrinologist in Stony Brook who was doing transgender treatment to, hormonal treatment, and she gave a talk. And they were very happy with that. Okay, so we had the input of the students, what they wrote in these stupid questionnaires, and then also what they had a question, they had a place there where they could just narrate, say things about what was the best part of the class, what was the worst part of the class. The other things were like a Likert scale, was the class well prepared, not likely, little likely, very likely. So this can be analyzed quantitatively, and then the narration had to be analyzed qualitatively. The first time in my life I did qualitative research, I felt really strange. And then we applied statistical tests to the quantitative data. Okay, so they liked us. Course satisfaction was high. We were rated as good or excellent by 80%. Now, I'm saying this sort of ironically because this is something that is completely new to me, is how important it is to make the students happy. When we were students, we were supposed to make the lecturers happy. Things have changed. So now we have clients and we have to make them happy. So they were sort of happy. I don't really want to spend too much time on that. Some of the narrative content was interesting, so I give 3 examples here. So we did thematic analysis. When people were asked to comment on the class in a narrative, what did they focus on? What were the major themes? So one major theme was content and format. And they said the material was relevant, important, and concise. The independent learning project was a great way to learn about the subject. So this was something, feedback we were interested in, because we just made it up, this student project as part of the class. It looked like this was a good thing. Fantastic material, loved the focus on biological differences. Now, this is important. Myself and my partner in crime, we were both biologists. And it was very important to us to impart to the students that there are many physiological reasons for sex differences in medicine, and probably many more that have not been investigated because sex differences was not a popular area of research until very recently. You couldn't get it funded, and believe me, I tried. Importance and relevance to medical education and practice. Good. They hope, I hope so also, that this becomes a component of general medical school curriculum. So the students were saying, we learn things we have not learned in medical school. These are important things. We think this should be part of medical education. And then the third theme that sort of dovetails with the fact that they were really interested in transgender, we covered some really important areas like the health that would have not been covered otherwise. They're talking about LGBT. So we had a class, you may have seen, we had a class about lesbian health. We had a class about transgender. So they were happy with the fact that these gender minorities were presented in class and that we talked about it. And then suggestion for improvement, the repeated theme was we want to see patients. We want patients to come and talk to us and present their symptoms and, they didn't want to come. Okay, we tried. All right. So how do we evaluate the knowledge evaluation? The question, why are women twice as likely to go to the doctor? I'm a very visual person. I do imaging when I don't do this. So we decided to color code the responses. just for starters. So we look at all of the responses and we identify 9 major categories, okay? Category number one also because was the most common, is women go to the doctor more because of gender stereotypes or societal expectations. Women are weak, men are strong, men do not want to ask for help. This is the reason. I have to say, well, I won't say it now. Then the OBGYN package, this is what we expected to be the most common response. It wasn't, okay? And then things that we thought will crop up in the second time the question is presented after the class, and perhaps even before, the side effects and lower efficacy of interventions, the misdiagnosis, physicians' bias, we taught all of that. Lack of studies, higher prevalence of chronic diseases among women, and longevity. So these were the color codes, okay? Now I'm going to show you a color map of the pre and post. And so these are the pre-class responses from one iteration of the class. 24 students are represented here. And the landscape is very stereotypical, okay? The majority of the answers, and it happened in every iteration of the class. These are the OBGYN, okay? So yes, there is the second most common response was because of, reproductive health. But the most common response was sort of women go to the doctor because they feel like it. I will read you some examples. And very few identified other reasons that we talked about. This is sort of good news. This is the post-class, okay? So I hope you see, without too much effort, that the landscape has changed. The color choice has changed a lot. This is what we hoped. This is what we expected. So, but this turquoise thing really worried me. The fact also that there is a lot more text here that doesn't have a color, it's a good thing. This is people sort of giving us extra opinions about the class and life in general, or mentioning reasons that they thought about, which are probably right, but only occurred once, so they didn't get a color. So why were we so worried about the turquoise? Completely surprised and deeply offended. I mean, read this and cry, okay? How many old-fashioned sex stereotypes can you expect to read in one day from a group of 26-year-old fourth-year medical students in the USA of today? Women with less busy work schedule, vague complaints. Where's Timmy? I love Timmy. I may not have Timmy. There was, oh yeah, here's Timmy. So I really love this one. Women are in charge of the family health, so when they make an appointment for Timmy, they make an appointment for themselves at the same time, like with the pediatrician. I mean, like. And there was one recurring theme. I was looking at this like, where is this coming from? I mean, did they bring it from home or did they learn it in medical school? As you will get used to, probably will listen to me, it's both, okay? Women are more in tune with their body. Like half of the students use the same phrase. Women are attuned to their body. Someone must have taught them this. This is not a phraseology that you come up with So apparently there is some input in medical school that teaches students that women are in tune with their bodies and therefore they make more visits to the doctor. I do want you to read some of the post-class responses because I picked the ones that I thought are sort of interesting. Do you know what people with female reproductive systems are? Apparently, it's newspeak. This is how you're supposed to refer to women. Saying women is no longer politically correct. I mean, I gag when I read this, but so this is a person talking about, he's absolutely right. But I like the change, the choice of it. So you can see how the students express what we categorized as physician bias. A lot of times their pain gets ignored, and it has to do with hierarchy and lack of female representation in a lot of medical fields. And there is again, unmarked text here because it's not an answer to the question, but we were very happy to see it. My major takeaway is to listen to patients when they describe their pain. Okay. So this is the quantitative analysis of the input. So you know our categories by now. And you can see that before the class, more than 80% of the students chose some sort of gender stereotype as the reason why women make more doctor visits. And after the class, this has dropped to 30%. And not only has it dropped to 30%, it has become more nuanced. So before class, more students gave only one reason, stereotype, or two reasons, stereotype and reproductive health. After the class, the average was 4 to 5 items in each student response. So they did learn something. This is it. So we know we managed to reach 150 students and sort of perhaps change their mind. Hooray, that's really nothing. Okay, I mean, women are dying out there. So I thought, well, this is the year of COVID. We couldn't even teach the class. Okay, we couldn't even reach the 24 students because classes were suspended. So I reached out to my friends and relatives and people who know people who work on this area, and we organized this online Zoom conference. And you have the program over here with a link to YouTube, because a lot of the questions you have or should have that were not addressed in my lecture are addressed in this meeting that started there. How did we get there in terms of the religious background for women's discrimination in medicine? It's a fantastic lecture. You have to hear the one about religion. To what really ails women? What are the disease conditions that are impacting women's health? And some rebel-raising discussion at the end, including a person you may know. She's Swedish, Kajsa Ekis Ekman. She participated in our panel. And this is where we are now. So now, we went to Stockholm in a weekend, and I found this picture hanging there. This is a Swedish feminist. I cannot pronounce her name if my life depended on it, but do you know her? And I think it's from the 60s, and it says, physicians, men control medicine, and they say, we demand no more enforced motherhood. And I can't believe that we are still fighting the same battle now, but we are, okay? Who would have thunk that in 2023, women will have to fight for the right for abortion all over again? In the United States, in Poland. I mean, it's like, so where are we now? Pregnant women are still the most discriminated population in terms of medical treatment. So, like, nothing is safe. You know, if you're pregnant and you're sick, anything may hurt your baby. You stop being a patient. You're a carrier of a baby. Okay? So there's a lot of hypocrisy that goes in there, but pregnant women are the residual population of women that are still not allowed into clinical trials. Okay? So we never know, we will never know what is safe or not safe for women for their own health. You know? Pregnant women have health issues besides being pregnant because they're not allowed in clinical trials. Women, yeah?
I think we need to start to wrap up.
Okay, this is my last slide.
Okay, yes, thank you.
So women are still underrepresented in clinical trials, and analysis of clinical trials is still not done by sex or hormonal status. Actually, in terms of physiology and effect on drug response, etc., women come in at least 4 different flavors. Pre-puberty, post-puberty, very different. 2 12-year-olds, one is menstruating already, one is not. They come in with abdominal pain. The possible reasons are completely different. The 12-year-old who is not menstruating yet doesn't have ectopic pregnancy, but the other one might have. Pre-menopause, completely different landscape. Menstrual cycle, hormones affect your response to drugs. So it's very important to question women where they are in their hormonal life when you intake them for anything at all, not just for OB/GYN. It's not done. It's very hard to get it in. I didn't mention violence against women as a determinant of women's health, but it's a very important determinant of women's health. 1 in 3 women is sexually assaulted during a lifetime. 1 in 4 suffers from domestic or intimate partner violence. This has effects on health. And in the US, for example, maternal death is increasing to dizzy heights as we speak. Every year it goes up. And access to abortion is decreasing, and the two are linked. And then we still have, we just saw papers from August 30th of this year, probably gender bias among male providers that leads to worse outcome in women. I had killing women before, and I thought, oh, this is too harsh. So we're still on a very long road to equity for women in medicine, and this is where we stop, and the next generations will thank you. This is a fetal MRI.
Thank you.